Now we're coming to one of the highlights of the meetings, is selected abstracts that were considered some of the best submitted. And the first will be by, pardon me if I mispronounce it, Kapildeo Lotun from University of Arizona. We're talking about hemodynamic support during cardiac arrest in the cath lab.
Thank you.
Something near and dear to our hearts.
Thank you for having me. I'm going to speak about the optimal hemodynamic support during cardiac cath during cardiac arrest in the cardiac cath lab. So it's a very small subset of patients, but I think it's an important one for us as interventionalists. These are the lab members, Dr. Trong, Kern, and myself. These are my disclosure slides. So I start with a case, a 58-year-old gentleman who has a known CTO of the LAD with prior stenting of the mid-RCA with a taxis stent about 8 years ago. He underwent left nephrectomy for a renal cell carcinoma, which was complicated by a SVC injury, and hemorrhagic shock, which is successfully treated with 10 units of PRBC. So they stopped all the antithrombotic therapy. So he became hypotensive the post-op day 2. This is the EKG. He went into, so we brought him to the lab, and even just as we are starting to get access, he went into VFib. So we defibrillated him. So he went to sinus for them for 20 seconds. So this kind of repeated again and again and again. So we started manual compression. So the next step is, code blue, start ACLS. We use the JL4 guide and plan to extend the RCA or start mechanical circulatory support or other options. So, which brings us to this, that the goals of therapy in cardiac arrest in the cath lab is actually very complex because these are really sick patients. They're a compromised group of patients. So there are two goals. One is to maintain vital organ perfusion. The other one is to correct the precipitating cause of cardiac arrest. And usually that's PCI. And these are two very competing goals because on one hand, you're trying to perfuse the whole body, and then on the other hand, you're trying to work to correct that. So there are certain challenges of manual chest compression in the lab. So it's very difficult to deliver very high quality chest compression. It's limited space. You cannot pan the table. Your hand is stretched for the rescuer, and then it's often interrupted by the operator and the defibrillation. And then for the rescue itself, you have the hands directly on top of the X-ray beam, and the head, especially, is actually very close to it. So the ideal mechanical circulatory support will be to provide an adequate vital organ perfusion, readily available, and can be initiated quickly with low complication rate and low cost. So there's certain devices which are available. There's a mechanical chest compression devices, the Lucas, LifeStat, and Autopulse. The MCS, Impella, ECMO, IBP, really does not do anything much for native cardiac function, and the tandem heart, which is really impractical during a code situation. These are the mechanical compression devices, the tandem heart. Usually the right-sided, we have 2 devices. This is the ECMO. I think you guys have seen this before, the tandem heart and the Impella. I'll go through these. So there's some data in the past which have looked at manual compression in CCL. There's some prospective study, really, but most of the study, the basic thing is that manual compression doesn't do good, and then the neurologic survival is actually very low. So I'll just skip to these and go. So our study was the specific aim was to compare manual chest compression with a Lucas device and an Impella device to see what happens during a code. And we tried to simulate it in swine models in a cath lab. So our primary endpoint was to look at neurologic function in survivors at 24 hours, and we had secondary endpoints of defibrillation success, ROSC, and some of the hemodynamics. So we usually get access in the carotids, and we put a JL4 We put a JR4 catheter in the coronary, the wire. We put a balloon in the LED. We have a pacer in the RV. This is the Impella device in the LV. And we inflate the balloon in the LED, and then after we inflate it, we use the pacer to initiate refib. So we had 2 phases to our study, a phase 1 and a phase 2. In the phase 1, so we occlude the artery. After 1 minute, we induce the cardiac arrest. And after 2 minutes, we started either Lucas device, manual compression, and we already have, in the Impella group, we have the Impella in place, and we started at 2 minutes. At about 6 minutes, we opened the artery, and then, which was followed by a defibrillation at 8 minutes. And we looked at return of ROSC within 20 minutes or so. And then if they have ROSC, we will look at them, we'll observe them for 24 hours. In the second phase, it's a similar setting, except that we increase the defibrillation rate up to 12 to 16 minutes. So these are the results. In phase 1, we had 10 patients in the manual group, 10 patients in the Impella, and then 10 patients in the Lucas group. In the phase 2, similarly, 10 patients in manual, 18 in the Impella, and 17 in the Lucas group. These are the results of the phase 1. So when you look at ROSC, there was 30% in the manual group, about 90% in the Impella, and about 80% in the Impella, and then 90% in the Lucas group. But neurofunction was, again, only 40% in the Impella group compared to 20% in the manual group, and about 70 to 80% in the Lucas group. In the phase 2, we skip this one. In the manual group, when we increased the time of defibrillation, there was no patient. So about half the swines achieved ROSC, compared to about 77% in the PVAT group and about 60% in the Lucas group. When we look at recovery of neurologic function, there was none of the swines in the manual group achieved neurologic recovery, compared to about 33% in the PVAT group and about close to 28 to 29% in the Lucas group. When you look at so again, this is the 24 hours survival recovery in the second group. Lucas was about 29, PVAT was 33. When you compare a device to a manual, I mean, this was significant that either one device actually did okay. So when you combine these groups, the phase 1 and the phase 2, I think the devices do a very good job at achieving ROSC. But when you compare that to a 24-hour neurologic recovery, I think both devices, I think they fall short. They're about 33 to about 40%. This is some of the tracings during resuscitations. This is during manual compression. This is with Impella without chest compression. And this is the Lucas group with the CPR. So they maintain about a mean pressure about 50 or so, but somehow the manual chest compression was not good enough. So skip this. This is the achieving, this is the coronary pressure during pre-epinephrine and post-epinephrine while we are trying to defibrillate these animals. And again, I think the Impella and the Lucas group actually did pretty okay. So the discussion goes around this, that mechanical support devices are really good at helping to achieve ROSC in the cath lab. However, what happens to a neurologic deficit, it just remains. We think that the right ventricle support is an issue because there's probably not enough. So you could decompress the left ventricle during the VFib phase, but I think there's not enough which comes back. I think there's a lack of pulsatility or driving force which can cause the tissue perfusion. So in our case, We actually did CPR. We inserted this. We actually initiated CPR. We put an Impella right away. We went ahead and fixed the RCA, and the patient actually, we shocked him out of it, and it was okay. So this is just showing that, while putting the Impella in, if someone doing CPR, this is always the issue with someone in the hand with the rings on it. And this was the left side. So where do we go from here? I think what we think that you should, probably a combination of different mechanical support, we call it a combo group, will probably help solve some of the issue of the neurologic recovery. The other thought process is that we probably keep the same VFib time, but increase the support time, i.e. leave the Impella in for a bit longer to see if there's ROSC and neurologic improvement. So in conclusion, I'll say that cardiac arrest in the cath lab is a devastating event and will be more common with, especially with all the high-risk PCI we do. I think the mechanical compression devices will offer unique advantages of manual compression, but we need to really get more data on this. Thank you.
Yeah, any questions from the panel? Or, yeah?
Oh, I just had a couple of quick questions. So one is, how are you assessing neurologic function in the swine 24 hours? Like, what is the definition of that?
So a very good question. So there is an independent veterinary who's blinded to this, and they look at it. They look at their gait. They look at if they're delirious. If they are feeding. They look at. So there's 5 or 6 criteria they follow, and that's how we usually. It's been described quite well.
Yeah, that was one. And then the other thing is that just technically from the image you showed of the swine fluoroscopy, the Impella from the femoral in those swine, the outflow is pointed into the descending aorta.
I'm sorry. Sorry, there's too much.
When you look at the fluoroscopic image in the swine model, the Impella from the femoral, the outflow is pointed into the descending aorta because of the way the Impella comes around.
It just the way the swine heart is. It's actually really looks like it's actually in the descending aorta, but it's actually in the LV.
So in our lab, we switched over to a carotid approach so that you could actually get ascending perfusion. Because if your perfusion's not getting to the brain, then you're dumping it into the descending aorta. It may impact some of your outcomes. So just technical things to keep in mind.
Oh, that will be helpful. Yeah.
Please.
We are using the Lucas device in a clinical setup in the pre-cath lab phase of CPR, and we see a high rate of damage done by the device by having multiple rib fractures, pulmonary trauma, lung bleeding. We have had several patients who bled to death after this manual compression. So I think this is in the clinical setup, this is certainly something to keep in mind. Then when you start doing mechanical CPR, then you put a damage to the patient. So avoiding shock, avoiding CPR, possibly by putting a device early before complicated procedures, may eliminate that risk altogether.
So I think, if I understand your question correctly, you think that prophylactically you should be able to put the device in, but majority of the time.
Just on your last slide, you say you expect that complications, complicated procedures to become more frequent, and therefore CPR in the cath lab becomes more frequent. I think we should work towards an era when we don't see CPR in the cath lab anymore, by detecting difficult cases and prophylactically protecting their hemodynamics.
Absolutely. I think, and I think for the high-risk PCI we do that, but sometimes we have left main dissection, so there are other times when we, like for example, the case we are doing the right coronary. I mean, we don't get that many times that we have cardiac arrest from a right coronary when you have a left intact system. But I think this happens quite, not frequently, but it happens often.
What kind of flows were you seeing?
I'm sorry?
What kind of flows were you seeing on the device, especially when they were fibrillating?
So initially we actually tried using the CP, And the CP was giving us way too many suction alarms because it really has to do with the swine models. And even though we used bigger, their weight was on the higher side, like 50 or 60 kilos. We are still getting 60. We're still getting a lot of suction alarms. So we actually switched to a 2.5, and when we switch to a 2.5, the flow is close to about 1.7, 1.8. That's pretty much it, what you will get.
And a follow-up question to that. The resuscitation process, particularly after VT, VF, tends to be very dynamic. And so after you administer epinephrine, defibrillate, all of this stuff, what kind of blood pressures did these pigs have?
So the blood pressure in these, those who we achieved ROSC, the blood pressure was about 80 or 90 or so. But those who didn't, we stopped ROSC, trying to achieve ROSC for about 15 to 20 minutes after we have defibrillated them.
Yeah, because one of the challenges is that the device is not effective if the return of circulation is followed by a really hyperacute hypertension. So if their blood pressure goes up, way up, then there's not effective unloading and no coronary perfusion, cerebral perfusion.
Thank you.